Hi, everybody. My name is Lauren Beaumier. I am a therapist at Laureate Psychiatric Clinic and Hospital, and I am super excited to be moderating tonight. I have just wanted to say thank you for coming and spending your evening with us at the Medical Town Hall. We are specifically going to be focusing on tonight Mental Health Awareness Month. I get the honor of introducing my wonderful friends and colleagues. We're going to be introducing Dr. Sarah McClanahan, who is the Executive Director of Behavioral Health at Laureate Psychiatric Clinic and Hospital, and Dr. Jimmy McAdams, who is the Medical Director of Geriatric Psychiatry. Dr. McClanahan is going to be talking today about emotional health and well-being, and Dr. McAdams is going to be talking about some cognitive issues and memory issues. So without further ado, we're going to dive right in, and here's Dr. Sarah McClanahan.
Thank you, Lauren. So I just wanted to touch briefly on emotional health and well-being. First of all, what is emotional health? Emotional health is our ability to feel, think, act in ways that enhance our ability to enjoy life, face challenges. When emotional health is not in check, this can lead to develop a mental illness, substance abuse, and also affect our physical health. So when we think about health, emotional health is necessary for total health. We can't be healthy physically if we're not healthy emotionally. Emotional health problems, they're common. A lot of people experience mental health issues, and a lot of times they are disruptive. They cause disruption in family, they cause people to miss work, they cause people to have disruptive relationships. They can be expensive, so we know that poor emotional health can lead to not only increased cost in care through loss of work, disability days, but it can also lead to increase in physical health care cost. And they're often undertreated. A lot of people don't want to seek help for their mental illness or their emotional health problems due to stigma. And so it makes it difficult to make sure that people are adequately treated. These are some symptoms of poor emotional health. So it's okay, we all have bad days, but when you start to have a bad day and you feel like you're not bouncing back as much, you're sleeping too much, maybe thoughts of suicide, difficulty, kind of completing your day-to-day activities and functioning like you should. So stress on our body can affect us in multiple ways. We know that stress releases chemicals in our body that can lead to all sorts of increased physical health problems. So I wanted to share with you some top 5 ways that you can improve your emotional health and stress relief. So the first one is making sure that you're getting adequate sleep. It's important, just like for babies, to try to have a time where you go to bed at the same time and you get up at the same time, and that you make sleep a priority. We know that having poor sleep can also contribute to physical health problems like obesity, which can also have its consequences on our cardiac health and things like that. The second thing is exercise. It's recommended that you exercise for 20 to 30 minutes about 5 days a week. And so whatever that looks like, getting out in nature, exercising, walking, something like that can help reduce the stress burden in your life. Relationships, making sure that you're maintaining that support system that you have to help to support you in the difficult times. Limiting alcohol and drug intake. And lastly, finding ways to relax, whether it's meditation, yoga, different mindfulness techniques. So getting help, like Lauren said, we are affiliated with St. Francis. We're the Laureate Psychiatric Clinic and Hospital. We're an entity of St. Francis Health System. We're just up on the hill right behind here. We offer a variety of treatment, both inpatient and outpatient services, depending on the need. We have a clinical assessment department that is open 24 hours a day, 7 days a week, 365 days a year to provide clinical assessments to those in psychiatric crisis. Also, within the last year, we've had a new national suicide and crisis line that has opened up. This is 988. It can be texted, it can be called. It is staffed by people locally, so you have the opportunity If you or a loved one is in a psychiatric crisis, somebody can come and assess you and help you get the needs that you have. Okay, I'm going to turn it over to Dr. McAdams. He is going to update us on cognitive issues and memory, and then we'll open it up for questions.
Thanks, Sarah. Thanks for coming. If this is too loud, yell at her. She's going to turn it down. I think it's been about 4.5 years since I did one of these where there were actual people in seats looking at me. The last one I did, I was sitting in a little room right over there staring at a laptop screen, talking to maybe one person, no people, maybe 500-600 people out there, I have no idea. But it's good to have a little bit of feedback with the eyes, a nod here, a shrug, a shake of the head, a point of the finger, anything, I don't care. So, Dr. McClanahan wanted me to start with a trivia question because she knows I like trivia. So here is a question. I know there's at least one history teacher in the audience. There may be more. There may be history buffs. But of the audience here, what does the year 1907 represent to y'all? State of Oklahoma. Perfect answer because that is the truth. But also in 1907, there was a German neuropathologist who had this unusual young patient, about 57-year-old female, who just lost her memory, completely lost her memory, continued to decline, passed away. And since he was a neuropathologist, he did an autopsy. And when he sliced through her brain, he found these unusual plaques and tangles that we all are aware of now. And his name, Alois Alzheimer. So in 1907, Alois Alzheimer discovered Alzheimer's disease. Got named after him. I told Dr. McClanahan today, I always wanted something named after me. I've had one published paper in my lifetime, nothing. But I've also realized that there's only one thing worse than not having something named after you. It's having something named after you than being canceled. So I'm okay with it now. In the woke society, I realize that it's fine. So we're going to talk a little bit about dementia. I've said many times in doing these things, not just these things, talking to people, meeting with groups of folks, that I would never start a talk without explaining one thing. And this is, if you take nothing besides this home with you tonight, know that. Dementias and Alzheimer's, okay, they're the same thing. Dementia is an umbrella term. I used to work with a person over at Laureate named Jill. And Jill gifted me when she left the umbrella that we made that she would spin while we were up, and it had all of the little deals of umbrella. One of them was Alzheimer's, one of them was vascular, one of them was Lewy body. So it's kind of like cars. All Fords are cars, but all cars aren't Fords. So all Alzheimer's is dementia, but all dementia is not Alzheimer's. Alzheimer's is the most common one. About 2/3 of dementias are Alzheimer's. So it is the most common one that's out there. So, what's new in the world of Alzheimer's? This is where I swallow hard and just wish I had some happier news. Because the last two big things that come down the pike ended up not being big things. One of them got approved and quickly lost its approval. There was a lot of resignations through the advisors of the FDA because they didn't think it was worth being approved by the FDA. The latest one is one that was hopeful to be better, but it's shown to slow down the progression, but it's not shown to release it. We spent a lot, I'm not a researcher. Researchers spend a lot of time and money identifying biomarkers, things that you can see that tell you have this. And the two biggest biomarkers in Alzheimer's are beta amyloid plaques in the brain. We've got smart people out there who have figured out how to give you an injection of something that binds to that and lights up like a Christmas tree on a PET scan. So they can see that. These medicines were designed to go in and remove that. They do a really good job of it. Unfortunately, there's not a reversal in the memory loss and only a modest slowdown of the memory loss. Plus, plaques can get into the vasculature of the brain. So as those go away, sometimes you can have bleeds in your brain. So you have to have a monitoring system every so often to get a CAT scan or an MRI to make sure that your brain's not bleeding. Now, if I had bad Alzheimer's, I'd take a shot on a brain bleed if it made me better. But if it's just slowing me down, I don't know that I want to risk a brain bleed. So I'm not telling you not to pursue that. If you've got a neurologist or someone who says, I think this is what we need to do it. I'm just telling you, like I tell everybody when we start medicines for Alzheimer's, there's not anything that we have right now that is going to reverse it. Only things that'll tap the brakes and slow it down a little bit as we kind of go down the path. So that's Alzheimer's. You know, the other things, vascular is a real common thing. How do you keep from getting vascular? You try to take care of your heart. Why do you keep from getting Alzheimer's? You try to take care of your heart. So how do you take care of your mental health? You take care of your heart. You exercise, you eat, you cut down on your risk factors. You don't smoke. You don't have high cholesterol. You take care of your cholesterol with statins. You do things that you normally would do as part of your general health. You know, the one thing, and she said it, that you moderate your alcohol intake. There's some studies that show a couple of drinks a day, it doesn't have to be red wine, just a couple of drinks a day help people live longer. So that's it. So that's kind of where it is with Alzheimer's. I could keep talking about stuff, but y'all didn't come here to hear me talk. Y'all come here to get your questions answered. So, you know, I think we'll just open it up for questions. If y'all don't have questions, I'm sure either one of us could ramble on about some topic that might not be interesting to anybody in the room, use examples, etc. So, our moderator here is going to pretend she's Phil Donahue and do that. I do want to say one more thing. One, I don't hear as well as I used to. I wear hearing aids, so I might have to walk out to you to actually hear that. Two, at this very minute in Denver, Colorado, my daughter-in-law is in labor with my first grandchild. So if my phone goes off, I will be stepping aside and try to remember to turn my microphone off so y'all don't hear me acting like a happy idiot. So with that, I'll turn things back over to Lauren and she can get the ball rolling.
Excellent. Does anybody have a question for us right off the bat? Okay.
In reading about memory issues, how do you know maybe what are the signs? And the most common one I've seen, well, we all forget, I'm older.
Yeah.
But when you start putting your car keys in the refrigerator.
That's my line. You stole my line.
That's the red flag.
That's the red flag.
Okay, now there's got to be something a little more subtle than that, I think.
So
What
here
would be some of the red flags?
The common denominator of all dementias is memory loss. To determine what type of dementia it is, it's when that memory loss starts and how it progresses. But all dementias aren't just memory. They have to have other symptoms that go along with it. So when you start to have trouble with your memory, no matter what level you're having trouble with your memory, but you're also starting to have trouble driving, you're losing your way, or you can't dress anymore, or suddenly the remote control isn't within your ability, so you've lost the ability to do something, or you notice that you're talking and you know what you want to say, you just can't get those words out. So when you have two things together, no matter where your memory is, that's when you need to start worrying. But what you said about memory is correct. You know, everybody in this room, and if you raise your hand and say you don't, whatever, has moments where their memory lapses. Like you said, you know, I once upon a time spent a day looking for a set of car keys. To a point, I had it towed to the dealership and they had to build me a new fob and cut me a new key. It cost me like $600. Found them. They weren't in the refrigerator, thank goodness. But they were in a pants pocket that I thought I'd looked in the bottom of the dirty clothes. So I lost them, sure. And my kids would always say, I didn't lose it. I just don't know where it is right now. So there's a difference. And the other thing is, you know you've lost it. You realize you've lost it. Are y'all husband and wife? He's not blaming. What'd you do with my keys? I know you put them somewhere. That's when you start to blame others for your memory. And then you get irritable and defensive and things like that. So memory's the key, but memory plus something is when you really start to worry.
Okay, I have a question. Where do you go to get help with coping with someone who is continuously losing things.
Okay. Starting to get personal. Starting to get personal. The number one place I give people the resources is the Alzheimer's Association. ALZ.org. They'll hook you up with the local chapter. They have specialists. They have caregiver conferences. They have a lot of things. You know, it's the old adage, why do you rob banks? Well, that's where the money is. You know, if you need to know something about Alzheimer's, you go to the Alzheimer's Association and get that information from them. You know, since we're talking about coping, the number one piece of information I can give anyone in this room that deals with anyone with a memory problem is forget about arguing about it. Don't argue with someone with a memory problem. 2 reasons. 1, you're never going to win. And 2, you're only going to escalate the situation. The only time you should argue with someone or really put your foot down is if it's a situation where there's danger involved. Like you can't drive, you can't go outside by yourself, you're not mowing the yard, you have to really put your foot down. So Alzheimer's Association would be the best place for you to go, and they've got a whole cadre of activities, caregiver conferences, information, early planning, help you kind of direct to a point. Because if you truly have dementia, there's only one thing I can tell you for absolute certain, it's going to get worse. And so you have to start getting some ducks in a row about legal issues, wills, living wills, DNRs, trusts, things like that. And, you know, in today's world, it even gets a little more complicated because you have to have a certain spin down, as they say, if you're going to use a nursing home and not have to pay for it yourself. So you have to shadow and shelter some of your benefits. Otherwise, the state of Oklahoma, if you're in the state of Oklahoma in a regular nursing home, is going to want that. Now, they won't want everything, but they'll want some things. They'll want some things.
Okay, we'll go right here.
She's the moderator. I'm not pointing at anybody now.
On drinking, the latest that I've seen says anybody under 40 shouldn't drink at all. But there is a slight advantage for your heart, but it's offset by the negatives. But after 40, they're saying we can drink a little, 1 or 2 a day.
Well, you know, I have a lot of people who just need any excuse at all to drink. You know, it's like a lot of things, you know, it's okay until the next big study comes out, you know, and you'll get that British study that says, you know, 2 drinks a day increases especially in women, increases your risk of colon cancer. You know, there's a big study out there, I think it's University of Minnesota, called the 90-year-old study. It's 90 years old to get into it. And once you're into it, they follow you to death. And then they do an autopsy and they do all sorts of things. There's a few things, and one of them was drinking, that extended their life. So, you know, I'm not up here, trust me, don't go home tonight and say, McAdams said drinking's good for you. Let's go get a bottle and split it. Not saying that. I'm saying that alcohol in moderate levels can be helpful. And it used to be red wine, now it's just alcohol.
You're saying correlation isn't causation, but there is a correlation.
There is a correlation. But you know, there's probably a correlation between the air we're breathing tonight and some sort of cancer. We just don't know it yet. I mean, you know, how long was Zantac on the market? As long as I can remember, like back in the 80s, and all of a sudden, what does Zantac cause? Cancer. Cancer. You know, how long was the NSAIDs out before they realized they started to potentially cause heart attacks and strokes? Long time. So I don't know. Like you said, causation, maybe sometimes you just have to wait and see.
Excellent. We'll move on to the next question.
We hear a lot about what causes Alzheimer's, contributes to it,
Yep.
what helps you not to have Alzheimer's. I'm hearing Splenda is a really bad one. There's all kinds of things that we intake, that we eat, that can be contributing to that. Medications. So what causes Alzheimer's?
You know,
The heart?
No.
Okay.
No, it's not a heart. You know, there are a lot of things. It's a multifaceted illness. It's not just one thing that caused that. When I got out of medical school and training, everybody was throwing away their aluminum pots and pans because there was a big rumor that aluminum caused Alzheimer's. No. You know, there are abnormal genetic things that can contribute to Alzheimer's. You know, apoallele AE4 is probably the most common one if you read about it. A duplication of that may contribute to you getting Alzheimer's, but people that have it don't necessarily get Alzheimer's. So don't run to your doctor and say, I need an apoallele AE4. Or you can go to 23andMe and they'll just give it to you as part of your package. But that doesn't mean you're going to get it, doesn't mean you're not going to get it. There are types of Alzheimer's that are purely genetic. The presenilin, the 40-year-old Alzheimer's that start getting it when they're 40, they're genetically predisposed to it, 50% chance. If you got a mother or a father that have it, you got a 50% chance of having it. And if you have it and you have a kid, they got a 50% chance of having it. So there's a lot of things, you know, what protects you from it? Absolutely protects you from it? Nothing. Absolutely nothing. What can protect you from it, can help you with it, or are the same things that she talked about. The diet is probably a little more specific with people with Alzheimer's, and it's high fat, good fat Mediterranean diet. So, you know, no dairy, no red meat. I always tell people eat like a bear, a lot of fish, a lot of berries, a lot of green stuff to do that. So there's the Mediterranean diet, which is easy to find, but there's also called a MIND diet, M-I-N-D, which is similar to that. So doing that. The other thing, you know, again, this also goes back to mental health, is socialization. You got someone to be around, you got someone to do stuff with, you got someone to interact with, that's important. Other things can be the exercise that she talked about, keeping your heart healthy, decreasing your risk factors. All of those things can be important. Exercising your body and your heart, but also you got to exercise your mind a little bit. That's why socialization can help, and that's where activities can help. And I'm not talking about doing the same thing you've been doing for 40 years. I have a lot of folks that have this disease that are piano players. They can still play a beautiful piano, and that's great, but I tell them you need to go get some different music. You need to get something you don't know how to play and try to learn that, because we know that when you learn stuff, your brain creates new connections and the neurons talk to each other in different ways. So keeping your brain healthy by exercising your brain. So diet, socialization, exercise, brain exercise, those are ways that you might mitigate things. And cognitive altitude, i.e. the higher you start before you start getting demented, the longer it takes for it to be for you to be affected by it. So lifelong learning is important. Getting your cognition, your thinking, your memory, you're as sharp as you can get it in case it does come, and then you trail. You know, it depends, and I don't always know what people's baseline is when they were 40, but I know what mine was. And if somebody gave me a MOCA or gave me a screening exam and I missed 2 or 3, I'd be scared. I'd be really scared because I shouldn't miss any. I shouldn't miss any. These tests aren't tricky. They aren't hard. They're just see if you can focus, concentrate, and remember. And when you stop doing that, that's when you start to worry. My throat's getting dry.
Thank you so much. We have another question here.
I have lived in Tulsa for 57 years, and I'm from Finland. And I'm in contact with friends and family all the time, and I speak Finnish with them. And then I understand what they're saying, but I have a hard time remembering to say those words to them. But then afterwards, I have a hard time remember the English words. And I'm just kind of confused. Why do I forget the English words that I normally would know? Is that sign of memory loss?
Not necessarily a sign of memory loss. I mean, it can be, but it's not necessarily a sign of memory loss. Languages are difficult. You're bilingual, maybe trilingual, I don't know.
Or
quadrilingual, you know, which is a good thing. I'm unilingual. I speak very minimal Spanish, so I can only imagine what it takes for your mind to manipulate those words and turn them into Finnish, or the Finnish words and turn them into English. You know, it is common when someone is Finnish your native language.
yes.
Yeah, it's common as people get older, if they do have cognitive problems, they do develop dementia, they eventually revert back to that common first language, where Finnish is what they're speaking. So, you know, I've had people that, if they're speaking Spanish, it's pretty easy. Now we've got the Marty, which is a language app that we can use that'll translate anything. But back in the day, we didn't have that. And so I had one lady who spoke Hungarian. That's all she spoke. Now, she used to be fluent in English. I had another Spanish lady, which is kind of easy to do. She used to teach English at Georgetown University, but she forgot all of her English. All she spoke in Spanish. So, in situations like that, that would be something that would probably, I would say, talk to your doctor, let him do a little screen and see how the rest of your cognition is. But just that language thing by itself, I don't think would meet the criteria to say that you've got a memory problem.
No, but normal words that normally I would know, they asked me,
Sure.
and then I don't remember.
Yeah.
Right now,
Well, the other thing is, I don't know how often you speak Finnish.
often.
Often. That's good because it's like that thing,
Several
I
times
speak
a
it
week.
twice a year. It's hard to keep fresh.
Several times a week.
Good.
It's either writing or talking. I'm in contact with friends.
Yeah.
And I spend 3 months every summer at my cabin in the National Forest in Finland, getting ready to go June 6th again.
Lucky you.
So my Finnish is constantly refreshed.
So when you're over there, do you find you speak it easier? Stay more
It
fluent?
It comes easier, but it's like, normally, words that I know in English, sometimes I'm just like, what the heck? I don't remember that word now. And I normally wouldn't remember that word.
Again, remember, it's going to take more than just one specific area. Just like he said about memory, it's the same way. It can't just be just language. There's got to be other things. So if you're just having trouble with language only, that's not probably enough to say that you've got a dementia.
Well,
But as I tell everyone, if you're concerned about your memory, that's enough for me. You need to go see somebody and get it evaluated.
But I
Because
know it's different. But another thing, I go from one room to another, I always forget what I'm going to go get. Then I have to walk back, and then I remember.
again,
And that happens to me daily.
everybody in this room's chuckling, including me.
Okay, that's my big problem.
Thank you. Of course, we're going to kind of answer some more questions on this side, and then I promise I'm going to come over on this side too. Okay, you said you had a question?
How does polypharmacy tie into this? If you're not just on one med, but you're taking many medications, I mean, surely that's got it. People I know that are on lots of medications, they're never clear. I mean,
That's a great question. Polypharmacy can definitely play a role, and sometimes we'll see polypharmacy playing a role in an acute change in mental status. So if a medication has been added or a medication has been increased, you might see that your loved one might appear more confused than they were a couple days ago. I know I was always trained in medical school and residency to start low, go slow, only start one medication at a time. We also recommend avoiding medications like benzodiazepines. So those as an anxiety medication that can also contribute to confusion and memory loss. Medications like Benadryl that you might use to sleep, like a Tylenol PM to help you sleep at night. That can also lead to confusions and can also put you at risk for falls. And so it's always important that when you go see a new doctor or you're maybe going to an urgent care that you let them know, here's my current list of medications, so they can make sure that they're not adding anything that may interact or have additive effects that could cause a confusion problem.
And that med list should have your over-the-counter medications on it too, because everybody thinks anything about over-the-counter is safe and easy. But the medicine she was talking about for sleep, if you do have memory problems, it's going to make it worse. Now, your question, I'm going to see if this is something that you were asking. Is there a medicine that you can take that leads to dementia? Okay, but you want to know that. Yeah. The answer to that is we're not sure. I was reading something the other day where it was just talking about just a regular sleeping pill. Does it contribute to dementia? Ambien, does it contribute to dementia? Antihistamines, early on and chronic use of them, not later on, because it can certainly make things worse. So there's always those papers There's always that paper that someone does a review of all of these patients on certain medications and see if they develop dementia. But again, causation, correlation. Can't say it. I mean, there's a lot of statistical analysis that goes into these things to try to rule out chance of this happening. But I don't typically, take people off of a lot of medicine when I see them. It's like Dr. McClanahan said, you start low, you go slow, and only start one medicine at a time. If someone's having problems with medicine, you can't jerk them off of everything that they're on. You gotta try to find a plan. And when someone comes in the office with their, Walmart sack or their Brahms sack full of pills, it happens all the time. I didn't make any slides tonight, but I've got a picture of the things sitting on my desk, and I pull them out and I start looking at them. There are pills from 2001. There are pills from last week. The pill bottle always has at least one pill in it. So I don't know if they're taking them, if they haven't been on them. A lot of times the pills that are in the bottle aren't the pills that are supposed to be in the bottle. So I try to make 3 piles when I go through people's medications. The no-no medicines, like she was talking about, the ones that can hurt you, benzodiazepines, sleeping medicines, antihistamines, anxiolytics like Vistaril or things along those lines, because those can be problematic. And then I make a list of the nice-to-have medications, which can be like arthritis medicine, things along those lines. And then the needed medications, heart medicines, diabetic medications, blood pressure medicines, because those have to be around. Now, when I was in medical school, many years after she was in medical school, we were kind of taught that most people would be on 1 pill per decade of their life. Well, I wish that. I really wish I could meet a 70-year-old that wasn't on more than 7 medications or a 60-year-old that wasn't on more than 6 medications. There's a lot of medications out there. Every medication you take has a side effect. Now, if you're taking 1 or 2 medications, you're probably going to miss most of those side effects. If you're taking 10 medications and they all have a little bit of drowsiness or they all have a little bit of dry mouth, guess what you're going to have? A lot of drowsiness, a lot of dry mouth. So, as Dr. McClanahan said, very important for you and your doctor to know exactly what you're taking. Now, I'm not plugging St. Francis tonight, but I'm wearing a pink tie, so that should tell you something. If you have all your doctors within St. Francis that work on Epic, your med list goes with you from doctor to doctor. You don't have to take it. The other thing that Epic is really good at, every time you write a new medication, it checks to make sure that's not fighting with that one or this one interfering with that one. So those things can be very helpful. Now, if you're in a small town, you see a doctor, no big deal. But, in the big city, you're seeing, your primary care doctor, you're seeing a cardiologist, you're seeing a psychiatrist, you're seeing a rheumatologist. And if all of them are in different silos prescribing you medication, next thing you know, you're on 3 or 4 things for the same thing. One of them's got a generic name, one of them's got their real name, and, most people, if a doctor puts them on a medicine, they're thinking, I probably should take this. So the next thing you know, you're kind of sleepy all day, stumbling, falling, doing things like that. So polypharmacy, I say untargeted polypharmacy is bad. Some people's blood sugar or blood pressure isn't controlled unless they're on 3 medications, and that's just the way of the world. But just throwing medicine at something and hoping it sticks, that's not a good idea or a good plan at all.
I'm wondering some help in helping a person who has been diagnosed with general anxiety disorder.
So just like the Alzheimer's Association, we have the National Alliance for Mental Illness. That's NAMI, NAMI.org. Is probably the best place to start. We have a local chapter called NAMI of Tulsa. NAMI offers all sorts of local support groups, not only for people that are suffering from a mental illness, but for their loved ones that are trying to help support them through that. And so that's where I would go for there.
Okay, great. We have another question right over here.
The biggest problem I have is waking up in the night and I can't go back to sleep. And so then I'm dopey the next day and I'm tired and I'm, and you keep on going. But are there any strategies you can suggest that lets you go to sleep without taking,
Without doping yourself up.
And
that's what I mean. There's a lot of strategies, but some of them are just hard.
And it doesn't matter if I ate late or if I had a glass of wine or this. it just happens. Go to bed, go to sleep immediately, and wake up at 3 o'clock, and that's it. So,
So a couple of things on that. First of all, I like to describe sleep as like a bank. So the money that you put in your bank account, the money that's in that bank account is the money that you can take out of your bank account. And so you have a sleep bank that renews each day with the number of hours that your body needs for sleep. And if you take from that bank 2 hours or an hour for a nap here and an hour for a nap there, that's going to interrupt your sleep at night. So trying to limit sleep, I know as you age, you might need that nap, but trying to avoid those hour-long naps during the day because that's going to disrupt the sleep that you get at night. Also making sure that when you're in bed, you're avoiding things like screens, so the TV, your cell phone, because that can activate your brain and tell your brain that it's time to be awake. So those are the biggest things that I recommend for sleep hygiene, is trying to go to bed at the same time every day and get up at the same time every day. And also with that, trying to avoid lying awake in bed, because if you lay awake in bed, then that tells your brain that when you're in bed, it's okay to stay awake and not go to sleep. And you want your brain to be trained that when you're in bed, you need to sleep. So another thing that I like in that too is with my children, when they were babies, I sleep trained them so they would sleep and I could go back to work and not be up all night with them. And they still follow that routine. My daughter will still come to me when she's tired, typically at the bedtime, and we'll go to bed. And we'll sleep through the night because I help train her brain that this is when you go to sleep, this is when you wake up. And even as adults, we still need that type of same training.
Very good. Okay.
Have you generally been a good sleeper? This has just happened recently? Okay. Yeah, as you get older, we lose our sleep efficiency, meaning the time that we spend in bed is a lot more than the time we're actually asleep in bed. So, the expectations of how many hours you should need to sleep should be realistic in the fact that you're not going to get 10, probably not going to get 8. 6 to 7 is probably the target you're looking for. And so, going to bedtime, as Dr. McClanahan said, is important, because if you're going to bed at 9 o'clock at night or 8:30 at night, 10 o'clock, 11 o'clock, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock. So, I always try to encourage people to stay up and watch the 10 o'clock news. Go to bed at 10:30. Oh, that's too late. Okay. Then, when you wake up at 4, that's not going to be too early, because that's the amount of time that you need to sleep. Well, then watch Gunsmoke. I'm just saying, 10, usually everybody knows that 10:35 is when the news goes off. So 10:30, that's my hope, that people can make it till 10:30. What time did I go to bed last night? About 9:45. So I'm preaching, but not following what I say.
Great. Okay, here's the next question. Oh, sorry.
Pardon? Don't read in bed. Don't read in bed. Reading puts me straight to sleep. Trying to read some stuff for this, straight to sleep. Straight to sleep. Straight to sleep.
Great feedback. Here's the next question.
Y'all may never get a question over here. May never get a question.
This is for Dr. McClanahan.
Good.
You mentioned earlier that there's a stigma about seeking psychiatric help. So if you have a family member or a group within the family that there's a lot of intolerance going on, how do you know that you need to approach this with perhaps a psychiatrist that might be able to give some direction there? Maybe someone's maybe needing some medical help through psychiatric medicine, or simply counseling or a life coach. How do you know what direction to go, and where do you start to find that answer?
So that's another great question. Again, I'm going to point back to NAMI, because NAMI has really good resources for how do I help my loved one? Where can I go? NAMI in your local community will also give you resources of where you can go in your local community to get help. So NAMI Tulsa has a wonderful book that they've put together that is for loved ones helping their family member or their friend who has been diagnosed with a mental illness. And it gives you tips of things to look for of when you need to seek help for that friend. And so things that I think of is people who are struggling with persistent depression or anxiety, or maybe they're confused or they're hearing things or seeing things, or maybe their mood is excessively elevated and it's starting to interfere with their ability to function, their ability to go to their job or to participate in things that they would normally do. Just kind of like what Dr. McAdams was saying about memory. We can all have times where we forget things, but if it's starting to interfere with your daily life in such a way that it's impairing functioning, that's probably time to seek help. A lot of people, probably about 50% of people will seek care from their primary care physician. So again, I know I'm not supporting wearing pink today. I'm wearing green in honor of Mental Health Month, but your physicians at St. Francis, if you see Warren Clinic physicians, they have opportunities to evaluate that, do brief screeners, and then refer you on to a psychiatrist if that's needed. Like I said earlier too, if you have a loved one in crisis, there is 988. This is the National Suicide Crisis Hotline that's actually answered by people here in Tulsa County or whatever county you're living in that can get you to the appropriate resources. If you have a loved one that is suicidal or thinking of hurting themselves, other people, they're unable to really care for their daily lives, you can call 911, you can call 988, you can take them to an emergency room, you can bring them to our clinical assessment department, because that's a more serious emergency issue that we would want to intervene in quicker.
I see a lot of ads for provision in the ads. Is there any information you have on provision?
Get that question more often than not just here. It's in my office almost on a daily basis. Somebody asks me about Prevagen. So when you look at medications to get approved by the FDA, the drug administration, the Federal Drug Administration, that says this is safe and this is effective, they have to go through a pretty rigorous trial where someone is given a drug that is real, someone is given a sugar pill. No one knows who that is or what that is. The doctor doesn't know. The patient doesn't know. And at the end of that, they crunch all the numbers to see if they got better or they didn't get better. If you'll notice at the end of that Prevagen commercial, or about half the advertisements on television, this drug is not approved by the FDA for the treatment of anything. Now, Prevagen won't hurt you. It hurts your pocketbook, but it won't hurt you. You know, I see those testimonials on television saying, you know, I was foggy-headed, I couldn't think, I couldn't do it now, take Prevagen, I'm fine. I'm not going to tell you not to go take Prevagen. I'm just going to tell you don't expect it to turn your life around, especially if you've got a diagnosable memory problem. That is something that's not going to be something I'd recommend you do, because one, it probably doesn't work, and two, it's going to cost you money.
Thank you, Dr. McAdams. We have another question right here.
Have you heard of any supplements that help with your memory from getting memory loss, like choline, I've heard is supposed to help?
So when you say choline, you know, one of the big neurotransmitter deficits in Alzheimer's is loss of acetylcholine. So people would think, okay, if I don't have that, I'll take a substrate that bills it. No. There's really only one pill, one thing that is shown, and it's only if you're low in it, and that's B12. Folate to a little bit of degree, but B12. So I always tell people, if you're worried, just get you a good multivitamin or a B complex, something along those lines. And Dr. McClanahan will tell you about a B vitamin that can help with depression, but that doesn't help with memory.
All right. Anybody else have any questions over here? Okay, great. I'm going to go this way, and then I'm going to come back.
I think she's left-hand dominant, always on that side.
I am. Who had a question? Okay.
Okay, I just had a friend who was diagnosed with mild cognitive impairment. and he had just recently had a stroke.
So mild cognitive impairment is kind of what it sounds like. It's mild, and it's typically, with mild cognitive impairment, there's an amnestic type, which is the most common type, which means it's your memory. You don't remember quite as well, but you don't have that multitude of other symptoms that would give you a dementia. And when you see this term, mild cognitive impairment, you're also going to see another term. It's called major neurocognitive disorder, which is now the newfangled term for dementias. Major neurocognitive disorder, Alzheimer's type, vascular type, etc. So with vascular issues and a stroke, if you have a stroke, depends on how big it is and where it is, of how it's going to affect you, whether it's going to affect your memory, whether it's going to affect your arm, your leg, your speech, and so things like that. But know this, that if someone has had enough vascular issue to have a stroke, they have other vascular issues. Probably have had some small strokes, some TIAs, things like that. And when you do an MRI or a CAT scan, you're going to see a lot of areas that the blood circulation has been cut off to, and that's usually what leads to the dementia. But just a small stroke in one or two places can leave someone, and you know, if he doesn't have another stroke or she doesn't have another stroke and takes care of everything else, maybe he or she doesn't progress to major neurocognitive disorder. Unfortunately, most people with mild cognitive impairment will convert regardless of what you do. Do all those things, but most of them will convert. They've looked at studies where people that diagnosed with or mild neurocognitive disorder or mild cognitive impairment and were put on medicines that we would use for Alzheimer's, like Aricept, Exelon, things like that, to see if it would slow the progression down before they converted. It really didn't. Really didn't.
Thank you. Did I miss somebody over here? Okay. Yes, I did.
Okay. You know, as women, we get pap smears, we get mammograms. Men have their prostate fun. I work in endoscopy. We do colonoscopies after a certain age. Do you see anything that's going to happen where, besides just waiting for the symptoms and the damage to be done, where they'll do maybe some, because you mentioned about like that, I think it was a CAT scan, where they...
Yeah, the first thing
like
would be just establishing that there's an issue. So it's a very simple test, and we do it in the outpatient clinic at Laureate. It's called the mini-cog. So we'll just play this game right fast. Everybody's got a pen and paper in here. I'm just going to tell you what, you can't write these words down. I give you 3 words to remember, and my words are always apple, table, and penny. Why are those my words? So I won't forget them. And then after you repeat those back to me so I know you heard it, I will tell you, now take your pen and paper and draw me the face of a clock. Put all the numbers in it where they go, and I'll tell you what time to put the hands. So, you know, I watch them do that because some people will get the circle, but they'll start with a 1 at the top instead of a 12. You know, so I need to see them do it. You can pick up a lot of things. I mean, some people have had strokes and have neglect problems will have all the numbers on the right-hand side of the paper. None on the left-hand side of the paper. And then have them draw that. Then I say, I want you to put the hands so the clock reads 10 minutes after 11. Always 10 minutes after 11. So why do you think it's 10 minutes after 11? My favorite time? No, not at all. Because there's no hand that goes to 10. It's a little sneaky, but there's no hand that goes to 10. There's a hand that goes to 11 and a hand that goes to 2. But when people aren't able to process very well, that instinct is to draw a hand to 10. And then, what are those 3 words? You don't have to say them out loud, but hopefully everybody remembers the 3 words, apple, table, penny. So here's the score. Mess up on the clock and forget a word, problem. Get the clock right, mess 2 words, problem. Those are the ones that you need to start looking at, and those are the ones you probably need to get a workup. So, you know, I don't know if your primary care doctors are doing that. I'm sure if you've been to a primary care doctor in Laureate or in St. Francis, you get a PHQ-9. That ring a bell? Do y'all get PHQ-9s in endoscopy when they check in? Oh, it's the 9 questions like mood. Yeah, that whole thing. Yeah, that one is a different one. But this one is a 1 to 4 rating, or 0 to 4 rating about basically the symptoms of depression. It doesn't say depression. It said, are you sad? Have you lost interest in things? All the things that she talked about earlier. And those are the things that screen, do you need mental health treatment? There's a GAD-7, a generalized anxiety disorder 7 scale. That's the same thing. If you meet a certain score, you probably need to be looked at a little harder. The mini-cog is the thing that we use to say, aha, you do this. Now I do geropsych, so I don't always do the mini-cog first. I'll do something a little more complicated like the MMSE or the MOCA, which are just initials for memory tests that I do. And that'll give me some idea of where they're at and whether they need to go. If they're on the border, then I might send them to Dr. Boatwright or Dr. Sherman or Dr. Hansen and get a full battery of neuropsych testing, which is about a half-day test. Pretty grueling. And it will ferret out just about all the things, even be able to give us some idea of what type of dementia it is, as opposed to just saying they have dementia. So, mini-cog. You're probably not old enough yet. You, if you're wondering. Yeah, well, okay. But I get it. Yeah, but, if you made it to 60, 70, I think it's 17% of people at age 70 have Alzheimer's. Yeah. So those of you in here that are that age or older and don't, consider yourself lucky. Because they're probably, I'm not trying to point anybody out because I don't know everybody in here, but I guarantee you there's somebody in here. Somebody in here, whether they know it or not, probably has it. Just hadn't been diagnosed yet or hadn't got to the right person yet.
Thank you. Did I miss
It's a
any
great
questions?
thought, right? I wonder if he's talking about me. He can probably tell from there, it's me.
I know. I was trying to keep it uplifting here. No, I'm kidding. Anybody have any questions over here? Okay, I'm going to go
Better
here,
ask fast.
and then I'll go in the back.
Get back on that side.
I go quick.
I quickly go to sleep and only sleep 5 or 6 hours. I've always done that.
Mm-hmm.
But now that I've gotten older, after I eat, I'll sleep about 30 minutes unless there's some interruption, and if it gets interrupted, I don't need it. Anything on that?
Well, Dr. McClanahan said, if you do take a nap, it needs to be short. Because that sleep bank she talks about is when you get down to the REM. If you're asleep long enough to get into the REM stages, that's where you're borrowing money for the night. So 20 minutes is usually kind of the number that you hear if you lay down and take a little 20-minute power nap.
Well, if it gets interrupted, I don't seem to miss it. Like
Yeah.
I get a phone call.
Because you
but
probably
if I
don't.
try to read, I'm asleep.
You probably don't. You probably don't. Yeah, all I have to do is read an article, like a scholarly article, and I'm out. And that could be noon. I don't care when it is. It just puts me to sleep. No, I said not in bed. I know, but you said when you read in bed, you go to sleep, so that could really... No, I'm not reading in bed, I'm reading in a chair. Well, yeah, I could bring you a couple of articles, probably just put you right out. Do what? Don't read in bed, because as Dr. McClanahan said, it trains you that bed is for reading and bed is not for sleeping. So if you can't sleep, you get up. And if you do read, low light, yeah, and something like I'll bring you if you need something. I've got all sorts of articles you could read on this very topic we're talking about.
Not being able to sleep, is that inherited? My mother, I remember, she never could go to sleep before 4 a.m. My grandmother was the same way. I cannot go to sleep at all without sleeping pill. I take one at 8 o'clock, go to sleep 2 or 3 o'clock. But I've had hot flashes for 33 years, and I wake up at least 5 times during the night after 2 or 3 o'clock, and I never, ever get a good night's rest. And I had breast cancer, so I can't take hormones, and that's the only thing that helped. I've tried prescriptions, every kind of natural remedy, and nothing works. how bad is that for you when you can never have a good, solid sleep?
Well, to address the first part of your question first, to my knowledge, poor sleep is not inherited genetically. Poor sleep can be inherited through example. And that's why I ask you, did you used to sleep well? Because some people, you ask them, when's the last time you slept well? My mom said I was a fussy sleeper, and they're 70 or 80 now. So, the realistic thing about that is they're probably not going to sleep correctly. Now, lack of sleep, sure, it's not good for you. Cognitively, it's not good for you. Health is not good for you. Dr. McClanahan says our cortisol levels go up when we don't sleep, can contribute to diabetes, can contribute to depression, can contribute to a lot of things. If nothing works, then there's no reason to take it. Because everything that you take has problems. And I don't know, I'm not here to recommend medications or to try to solve anybody's dilemma, but, some of the newer medications, the orexin sleeping pills, if you haven't tried those, that would be something you would talk to your primary care about to see if there's another type of medication that you haven't been on, because there's 3 or 4 that have come out over the past 7, 8 years.
Well, I have just a recommendation for sleep, and it's just a regular program of exercise. It has been shown to increase the depth.
It has, but you shouldn't exercise right before you try to go to sleep.
No,
yeah, because
I agree on that. I agree
that
on
will
that,
rev you up. Exercise during the day. And you start to see. Even y'all are bringing all of this stuff that Dr. McClanahan talked about: exercise, sleep, diet. All of these things are so important. Whether it's memory or depression or anxiety, all of these things, you can see there's building blocks that keep you well. There's here and here, there and there, there and there and there and there.
All right. Here we go.
Could you say a little something about Lewy body dementia?
Lewy body. I can. So Lewy body dementia, right now, from a standpoint of the primary dementias, which include Alzheimer's, Lewy body, frontal temporal, is number 2. So Lewy body is kind of a hybrid between dementia, the Alzheimer's type, and Parkinson's dementia. And most likely Parkinson's dementia and Lewy body are just along the same spectrum, because people with Parkinson's disease have Lewy bodies. And the reason it's called Lewy bodies is, how we talked about the plaques and the tangles that are in Alzheimer's brain. These are inclusion bodies that, of course, somebody named Louis got them named after him. Drat him. And so Lewy bodies, so when I talked about memory is the hallmark of all dementias, eventually it is, but presenting symptoms will help you decide what type of dementia it is. And almost always with Lewy body, it's visual hallucinations. And I'm not talking about thinking you saw, a shadow. I'm talking about, these 3 people sitting on the front row right there, and I don't know why they won't talk to me, because I'm pointing right at them and asking them a question, and they won't talk to me. That's the kind of hallucinations I'm talking about. That, and also people who wake up from a dream and can't get back to reality. They are fighting in a dream, they wake up and fight. They're running in a dream, they wake up and run. So all of those things that was going on in the dream, they act out when they wake up. Those are the 2 most common things that do that. I said it's kind of a hybrid between Parkinson's disease. Eventually, about 75% of them will start to have tremors, start to have the classic walking gait or the mass facies that come about. So it is one of those that, we're not talking about delirium tonight. Dr. McClanahan's going to do that at lunch at some point. It's pretty fluctuant. People can look good one day or look good in the morning and look really confused and having hallucinations in the afternoon. So it's a little confusing sometimes to differentiate that between someone who's got delirium because they've got an infection, or they've got a medication reaction, or they're coming off of alcohol or nerve pills or something along those lines. Treatment, not really. As far as stopping it, it marches on as well. You typically try to treat symptomologically. You can use the acetylcholinesterase inhibitors. Sometimes you have to use antipsychotic medications to knock down the hallucinations. But if you do use those medications, you have to be very careful what you use, and use the ones that aren't as potent as some of the others, because if you use a real potent antipsychotic, they'll basically just lock up. can't move, get stiff. That's never good. That's never good.
Okay, we have another question back here.
Yes, it's my understanding that Laureate has both psychiatrists and psychologists. Is that correct?
Correct.
I'm trying to figure out if a person had an issue, would they go to a psychiatrist first or a psychologist first? Because I know one is an MD.
Yeah.
But I think both can prescribe, can they not?
No.
Well, some states I think you can.
One state. One or two states.
Okay.
New Mexico and Louisiana.
Okay.
Mexico and Louisiana. You know, it's a hard question to answer because you can really start with either one. Now, you know, a lot of times, you know, whether they're a psychologist or a therapist or a social worker, they will start with them and then they will recognize that they probably need some medication to help them with the problems that they're having, and then they'll send them down to one of us. So eventually you may be seeing both. If you are, who asked the anxiety question? If you're an anxious person, you should be seeing both. You should be seeing that therapist to help with your thinking, and you should be seeing that psychiatrist to help with the medications to help control your thinking. So, to who you see first, probably not that big of a deal. Now, if you're floridly seeing things and hallucinating like those three people sitting there on the front row that won't talk to me, you probably just might as well start with the psychiatrist because you're going to need some medications. If you're depressed or anxious, you're depressed, you're not acutely suicidal, you're depressed and you're not psychotic, or you're acutely anxious, or you have, you know, OCD, either one's fine. Either one's fine. Both can give you an accurate diagnosis, and then the psychologist can refer you to someone who can prescribe. Maybe back to your primary care doctor with recommendations that you go on a medication for whatever you're seeing them for.
All right. Is there any other questions that we have before we wrap up? Okay, we'll do. That's how I'll do it. I'm a walking moderator.
Hi, I just wanted to ask the doctor up front, the lady, about the Tylenol PM and what you said about that. I'm sorry, could you repeat that?
So medications like Tylenol PM, Advil PM, they typically have an antihistamine like Benadryl associated with that. And we do know that long-term use of that can make you prone to memory problems. We also know that as you age and you take those medications, that can make you more likely to get delirium. And so delirium is a more acute onset of confusion that kind of waxes and wanes. And so we typically recommend that people avoid those medications so they're not getting that confusion. It can also make you at risk for falls, urinary retention, and have lots of side effects. So taking a Tylenol PM one night, probably not going to be a big deal, but taking it on a regular basis can definitely make it more prone for you to have problems with your memory or confusion.
Thank you, Dr. Clanahan. Sure.
On the Benadryl, I've been having a lot of problems with allergies and things like that. And sometimes I'll take a whole one, but sometimes I can take a half overnight and it helps. Is it better to take a half than a whole?
I would recommend that you talk with your primary care physician because there are medications for allergies that are not going to have these side effects that we're concerned about.
Thank you.
Of course. Okay. Back here.
I have several prescriptions, and they make my mouth dry all the time. I either have to have water or something to suck on. Is there anything that can help dry mouth?
Depends on the medicines you're taking. Are they the needed pile? You know, because the dry mouth is one of the things that these medicines that Dr. McClanahan has been talking about can cause. Dry mouth, blurred vision, constipation, urinary retention, dizziness, falls, bad juju. So I don't know what all you're taking, but again, if they're all in that needed pile, you don't have anything else, then you're going to have to decide dry mouth or heart attack, dry mouth or diabetes.
Oh, yeah. Well, I have all
of those?
I have, diabetes and high cholesterol and all of that. But the side effect is my mouth is dry always.
Sugar-free sour lemon drops.
What?
Sugar-free lemon drops. Get something pucker in your mouth.
Sugar-free lemon
drops. Something that's sour. Sour always makes you pucker up and then salivate. But not the sugar one, since you got diabetes. I don't want you getting on a sugar high.
So
there's also, as gross as it sounds, there's also stuff that's called artificial saliva. It's not from a donor. They don't have a factory where everybody goes and spits in a deal, but it lubricates your mouth. It's kind of a lubricant for your mouth.
All right. I just wanted to say you guys are a beautiful crowd. It's been so fun walking around, getting to see each and every one of you. We have had a fabulous time. Can we give it up for our wonderful presenters one more time? That's right. I don't know about you guys, but I learned a lot, and I was really excited to be here. So at this time, is there any final things that either of you would want to say?
No, I want to thank you all for coming. You know, these things, I think, are a nice opportunity to spend an hour getting your questions answered, because I know how it is when you go to your doctor. You've got the clock starts ticking when they open the door. So sometimes you don't always have time to sit around and just ask those things that you're just really curious about, kind of want to know, but don't think that important. So thanks for coming out. I'm sure in 2 years, Dr. McClanahan will do this again. Not speaking for myself.
Oh, you'll be back. Thank you, everyone, for coming.
Thank you. You're formally dismissed at this time. And
No baby yet. No baby. We're still good. Still good. Still good.
Thank you, guys.